From the JAMA Network, this is the JAMA Medical News Podcast, discussing timely topics in clinical medicine, biomedical sciences, public health, and health policy, featured in the medical news section of JAMA.
I'm Rita Rubin, lead senior staff writer for JAMA Medical News. Today we're joined by JAMA Associate Editor Dr. Kimmie Ng. Dr. Ng is Associate Chief of the Division of Gastrointestinal Oncology at the Dana-Farber Cancer Institute and Associate Professor of Medicine at Harvard Medical School. We're going to be discussing highlights from the recent annual meeting of the American Society of Clinical Oncology, or ASCO, in Chicago. Welcome, Kimmie.
Thank you so much for having me.
Our pleasure. Several interesting studies investigated the relationships between cancer and exercise, diet, and weight. One of these studies was the Challenge trial, the first randomized trial of exercise that found a survival benefit. Trial participants had stage 3 or high-risk stage 2 colon cancer. What's the takeaway for clinicians and patients?
I was extremely excited to hear the results of this study, which have been eagerly anticipated for many years. As you may know, there have been many preclinical and observational studies that have shown that higher levels of physical activity are associated with a decreased risk of cancer recurrence and improved survival in patients with colorectal cancer. But until this meeting, there had not been causal evidence from a randomized clinical trial about the benefits of exercise. So in this study, which was run by the Canadian Cancer Trials Group and conducted in Canada and Australia, they randomized nearly 900 patients with stage 3 colon cancer who had undergone surgery as well as chemotherapy for their cancer to either a 3-year structured exercise program with health education materials or just provision of health education materials in the control arm. And I want people to know that this structured exercise program was actually quite intensive. There were mandatory behavioral support sessions, there were mandatory supervised exercise sessions, all conducted with a certified physical activity consultant. But they succeeded in increasing the amounts of moderate aerobic exercise in the intervention group compared to the control group. And as you mentioned, showed a statistically significant benefit in the primary endpoint of disease-free survival with a hazard ratio of 0.72. So very exciting data, and really the benefit seen is equivalent to many FDA-approved drugs for this cancer in this space.
That's great. Did they also look at whether the intense exercise contributed to weight loss?
They did actually. And interestingly, there was no significant difference in body mass index or waist or circumference measurements between the two arms. And so largely the benefits are independent of weight loss. And what also was interesting is some people may wonder whether the benefit of exercise on survival is due to improving other health outcomes, but actually it was really through improving cancer outcomes because it was mostly related to decreasing the risk of cancer recurrence as well as the incidence of second primary cancers. So really, exercise is having an effect on cancer outcomes.
Wow, that is very exciting. Now, you're the senior author of an observational study that examined the relationship between a pro-inflammatory diet and outcomes for patients with stage 3 colon cancer. You also looked at whether exercise might attenuate the association. What is a pro-inflammatory diet, and why might it lead to worse outcomes in people with colon cancer?
Yes, we were also excited by the findings of this study, which really are supportive of the Challenge randomized trial that we just talked about. So it's been known for a while that systemic inflammation is implicated in colorectal cancer pathogenesis, and has also been shown that certain dietary patterns and foods can increase systemic inflammation. So we calculated a score called the Empirical Dietary Inflammatory Pattern, EDIP or EDIP, and tried to see if that score, which correlates intake of certain foods with levels of plasma inflammatory markers, whether that score is associated with outcomes in patients with stage 3 colon cancer who are enrolled on a national cooperative group clinical trial. And indeed, we did find that people who consumed a more pro-inflammatory diet seemed to have worse survival compared to people who consumed a less inflammatory diet. We also found that those who consumed the least inflammatory diets and also exercised the most had the best overall survival compared to people who ate more pro-inflammatory diets and had the least amount of exercise.
What are some of the pro-inflammatory foods and what are some of the anti-inflammatory?
So this score considered 9 food groups that are considered pro-inflammatory, and they're the usual suspects, red and processed meats, energy drinks, refined grains, and then also considered 9 food groups that are considered anti-inflammatory, including vegetables, coffee, and tea. And then they calculated all that together, depending on how much was consumed of each food group, to come up with the ultimate inflammatory diet score.
It seems like almost every week we hear about another potential use for GLP-1 receptor agonists. The weight loss and type 2 diabetes drugs that seem to have taken the U.S. by storm. An observational study presented at ASCO looked at the rates of 14 obesity-related cancers in 170,000 U.S. adults with both obesity and diabetes. The researchers compared people treated with DPP-4 inhibitors, a class of oral diabetes drugs not associated with weight loss, with patients who had been treated with GLP-1 receptor agonists. And they found that the patients who had received GLP-1 receptor agonists were a little less likely to be diagnosed with or die of the obesity-related cancers. Well, what are some of the most common obesity-related cancers? And do you think weight loss might fully explain the modestly lower risk of these cancers in patients treated with GLP-1 receptor agonists? Or could there be something about the drugs themselves other than their effect on weight?
Great questions. And for a long time, we have been wanting some data about whether these drugs can actually protect against the development of cancers that are associated with obesity. So some of the most common obesity-associated cancers include many of the gastrointestinal cancers, like colon cancer, rectal cancer, pancreatic cancer, and endometrial cancer and breast cancer are some of the most common ones that are typically known to have obesity as a risk factor. And although the exact mechanisms of how obesity may lead to cancer are not known, theories include that it promotes inflammation, dysregulates hormones, causes an immunosuppressive environment, and may modulate the microbiome in unfavorable ways. And so we saw from this study that there were modestly reduced risks of obesity-related cancers in users of GLP-1 receptor agonists compared to the DPP-4 inhibitors. And very interestingly, the association was largely driven by decreases in colorectal cancer, with a 16% decrease in colon cancer cases and 28% fewer rectal cancer cases. I also think an interesting subgroup analysis that they presented was that the benefit seems to be greater among women using GLP-1 receptor agonists, particularly for all-cause death. But whether or not these protective effects are true and whether or not they're due to decreasing obesity or an independent mechanism, nobody knows yet.
And it's also interesting because this study was done in patients who had obesity as well as diabetes. And so I guess we can't really say much about people who are just taking these drugs for weight loss who don't have diabetes.
That's right. Although there was a second study presented right after this one at the ASCO annual meeting that did look at adults with obesity and they didn't have to have diabetes who were using these drugs. And the results are different. There was an overall decreased risk of cancer in combination, but for example, they didn't see a significant decrease in colorectal cancer. So there are many conflicting results out there, and I think that some of the limitations include just very small numbers of cases of each of these cancers to make definitive conclusions about specific cancer types.
Well, speaking of colorectal cancer, there was another really interesting study that was published in JAMA during the ASCO annual meeting. The research was first reported earlier this year at the ASCO Gastrointestinal Cancer Symposium, but it did just come out in JAMA. And that study examined the use of a blood test for circulating tumor DNA to screen for colorectal cancer. Now, I know there's a great deal of interest in a screening blood test for colorectal cancer because it would be much less invasive than a colonoscopy, of course. Could you tell us about the study, which is the largest to date of a blood-based colorectal cancer screening test?
Yes. So, colorectal cancer is unique in that there actually is a really effective screening test for it, but there are also real barriers to many of these screening tests, as you mentioned. Colonoscopies are invasive and you need to get anesthesia and do a prep. And there are so many reasons why people also may not be willing to do stool-based tests, which are also approved for colorectal cancer screening. So, yes, a lot of enthusiasm about a blood-based test for colorectal cancer screening. So this study enrolled average risk adults age 45 to 85, meaning they were asymptomatic and who were going to undergo a standard of care screening colonoscopy. And they had all these individuals have a blood draw done for a circulating tumor DNA test from a company called Freenome. It does next generation sequencing and then uses artificial intelligence and machine learning based models to detect a unique methylation signature associated with advanced colorectal neoplasia. The primary endpoint was to clinically validate this test and look at sensitivity for colorectal cancer, specificity for advanced colorectal neoplasia, as well as negative and positive predictive values for advanced colorectal neoplasia. And they did find that all of their endpoints met their pre-specified thresholds with about a 79% sensitivity for detecting colorectal cancer and a 92% specificity for advanced colorectal neoplasia, which also includes high-risk polyps. So, this does add to the armamentarium of tools for screening for colorectal cancer. It does seem pretty equivalent to other blood-based tests that are now FDA approved for colorectal cancer screening, as well as many of the stool-based tests. But it's probably not as good as some of the multi-targeted stool detection tests that are out there, and certainly not as good as colonoscopy still, particularly for discovering pre-neoplastic lesions, which is really how you enable colorectal cancer prevention, not just early detection.
Do you think this test will fit into the armamentarium screening for colorectal cancer anytime soon? Or?
I do think that if the regulatory authorities approve this, it will become another way to do screening. The U.S. Preventive Services Task Force really realizes that there are a variety of different barriers for different individuals with any of these screening tests, and they really emphasize having a menu of different options for patients to consider in terms of what is the best screening test for them. And my takeaway has always been the best screening test is the one that gets done. So all of these are very effective screening tests.
Great. When I was switched to another type of cancer, there have been intriguing retrospective studies that have suggested that infusing immunochemotherapy early in the day rather than later increased efficacy. So at ASCO, results of the first randomized phase 3 trial to examine this question were presented. And in this study, 210 patients with non-small cell lung cancer were randomized to receive their initial 4 immunochemotherapy cycles either before or after 3 p.m., which I thought that was an interesting cutoff for early versus late. After an average follow-up of 19 months, the researchers did find a difference in treatment efficacy depending on the time of day it was administered. Now, could you give us a little more detail about what they found and why might the time of day make a difference in treatment efficacy?
I found this study to be fascinating. So there is a lot of preclinical data as well as observational data that circadian rhythms impact everything from sleep to disease incidence to treatment, and that they may be associated with how well your immune system functions as well. And there are multiple retrospective studies and meta-analyses that have seemed to indicate better results with immunotherapy when these drugs are given earlier in the day. You mentioned the cutoff of 3 o'clock p.m., and that was a question that was posed to the authors. And what they said was that they did do multiple sensitivity analyses looking at different time cutoffs for different times of the day and did find the most promising data associated with this 3 p.m. cutoff. I don't know that there's a biological rationale yet for that, but it was based on some preliminary analyses they did. So what they found was a doubling of the progression-free survival among patients who were receiving immunochemotherapy prior to 3 p.m., with an improvement from 5.7 months in the control group to 11.3 months in the early administration group. Also, they found significant improvements in the secondary endpoint of overall survival, again in favor of the patients who received these regimens earlier in the day. And then what I found very interesting was that they also tried to correlate this with immune cell subsets in the peripheral circulation. So they drew blood samples in the morning from everybody on the study at baseline and then after 2 and 4 cycles. And what they found was increased peripheral circulating CD8 positive T cells among patients receiving these treatments earlier in the day and a decrease in CD4 positive T cells. And when they did flow cytometry, they showed that the ratio of activated versus exhausted CD8 positive T cells was greater among the early time administration group. So perhaps the timing of administration of immunotherapy may indeed be affecting the immune system function in these patients.
It's so interesting. And I hope we'll see some more randomized trials and maybe in other cancers too to examine that question. And you mentioned that they showed a greater progression-free survival in the patients treated before 3 p.m. And that brings me to the last study that we're going to talk about. And that study was presented at ASCO and published simultaneously in JAMA Oncology. And it suggested that surrogate endpoints such as progression-free survival in phase 3 clinical trials of cancer treatments might not necessarily reflect what's most important to patients. What did the researchers conclude might be more meaningful endpoints for future late-phase cancer treatment trials?
Yeah, so the rationale for why the authors tried to look at this question are, just as you mentioned, alternative endpoints like progression-free survival are on the rise for phase 3 clinical trials, and for many good reasons. You get results faster, there are higher event rates, and so this leads to fewer patients being required to enroll on these trials, which reduces the costs of conducting these clinical trials, and arguably patients get access to effective therapies faster. But they really homed in on the point that the endpoints that matter for patients are overall survival and quality of life. And so, many of these studies now, although they report positive results in terms of the primary endpoint, many of them do not subsequently show overall survival superiority or quality of life superiority. They found that only 28% of the trials that reported positive results also demonstrated an improvement in overall survival, and only 11% demonstrated improvements in quality of life endpoints. And when you look at both of those important endpoints combined together, only 6% of those trials actually showed improvements in both. Now, there are some caveats to this, right? Many studies that are powered for a primary progression-free survival primary endpoint are not necessarily powered to detect the overall survival endpoint, but it doesn't mean it's not there. So I do think the study is important in that it does highlight the importance of paying attention to these really important outcomes. And I think it requires talking to regulatory authorities about how we may still be able to demonstrate improvement in these very important outcomes with these trials.
Well, thank you. I really enjoyed our conversation and appreciate your taking the time to talk with me.
Great to be here. Thank you so much for having me.
Sure, our pleasure. I'm Rita Rubin of JAMA Medical News, and I've been speaking with JAMA Associate Editor Dr. Kimmie Ng about research highlights from ASCO's recent annual meeting. You can find a link to the articles in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.